Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. Good afternoon, welcome to Monday's Lunchtime Learning. Once upon a time we used to do a series here of what we called product reviews. Essentially what we did we hoped were impartial looks at various types of equipment. And I suppose today's show is a little bit like that. We're going to be looking at the Össur unloader brace. And the reason we're looking at this particular piece of kit is because it was recommended to me by an orthopod who I've got a lot of time for, a chap who's been on the show on numerous occasions, Ian McDermott, and you might have seen him on some of our shows. Now, these braces are not cheap, but then neither is joint replacement surgery. What they do, though, is they promise in some cases to help at least postpone that surgery, and I thought it'd be a good idea for us to learn a little bit more about them. My guest is Giles Leeming. He's from Össur. He's trained as a podiatrist, but is now an orthotist with a lot of experience in this field. So, Giles, welcome to you.
Thanks for having me.
Yeah, I mean, I'm fascinated to see this because people refer, don't they, in general life, in clinical life, even to braces. But braces means a lot of things to a lot of different people, and sometimes they just mean a tubey grip or something like that, which does nothing to provide anything other than a bit of compression and proprioceptive support, I imagine.
Yeah.
What are we going to be looking at here?
Well, something a bit more involved, something a bit more designed very specifically for the patient group. And you're quite right, braces vary from a simple sleeve to something, again, more involved and that sort of thing. So it's often a discussion point for us in terms of correct prescription, making sure you got the right thing, but also having something that's designed holistically to suit the patient group.
Holistically?
Yeah, well, it's important if we're talking in the field of OA, for example, they may have OA in their knee, but there will be other associated issues with that. They may be more advanced in years. They may struggle with buckles and more complex things.
Right, yeah. Okay.
That we need to factor in from a design point of view and make sure that we've got something that really works for that person. Doesn't matter if we make the best biomechanical brace, if the patient can't tolerate it or use it correctly, it doesn't really fulfill that need. So we need to consider these things.
Well, I suppose there's, well, first of all, I mean, turning to Össur, the company, we're going to be looking at one particular type of brace, an unloader brace today, but I presume Össur does lots of other stuff as well. Yeah,
so our background's actually in prosthetics. So we were started by an amputee, Össur Christensen, and he was unsatisfied with his leg, and he developed a silicon roll-on socket, the IceROS or Icelandic roll-on silicon socket, to solve his needs with his leg. And from there we have things like the carbon fibre blades you see at the Paralympics. Most of those are from Össur.
I had no idea.
Yeah, and people like Johnny Peacock and Rich Whitehead are some of our athletes, for example. So,
What goes through my mind, though, and we've got an example of the brace that we're looking at today, and we're looking at a particular brace which is presumably designed for a particular condition.
Yeah.
And you'll tell us more about that. I guess we're all concerned about, what's the evidence for this? Because you can design a sexy brace with straps and buckles and all sorts of stuff, but people are going to be thinking, well, how much of it is necessary? What does the evidence tell us? Or how much of it is placebo or proprioception in much the same way as tubey grip?
Yeah, and it's important that there's a good research backing for these. It is, orthotics itself is a relatively small field, and it's important that we encourage research in this area. And we'll talk about it a little bit later. But for the unloader, for example, there is the broadest of any of the other braces. There is the broadest sort of backing of research in that area. The most research has been done in this.
So maybe I should let you, I know you've got some pictures and stuff like that, so I mean, maybe I should let you tell us about, what it deals with and how it works then before we get into how you use it.
So effectively from a brace point of view, it's important to consider the modality itself. It's a very sort of targeted methodology, with more systemic things like pain relief medication and that sort of thing. You are okay, you're aiming for pain relief from the OA, but it's a systemic thing. With this, it's affecting just the knee. It's extremely targeted for that area. Also, from mortality and morbidity concern, it's very isolated in terms of that area. So they can be very useful in patients that perhaps have other considerations, so things that may preclude them from having surgery, for example. So it's good with comorbidities and that sort of thing. And also, it's really important that we consider it as a combined therapy. So a brace in isolation, can be useful, but it's also really important that we consider it as a group with other conservative measures. So we have here, for example, injections, very much targeting the pain within the joint, medication, and then an unloading knee brace. Yeah. With those, we're really trying to target the discomfort, with the aim that potentially we can sort of break that antalgic side of things, and they can get more from manual therapy, they can get more potentially from diet and exercise if we're able to control the discomfort that they're feeling.
One of the concerns that people often have with any form of bracing is that by applying a brace, you are reducing the work done by the muscles. Therefore, you're encouraging sarcopenia in a certain population, or just muscle wastage. And that is counterintuitive when we think of strength being a major factor in overcoming OA. Or not overcoming OA, overcoming the pain of OA.
So that basically is from historic research. It was on a very different brace. So originally, this sort of in my early career, there was a study done that looked at ligament braces and their effect, very different style of brace. So the ones you might see on skiers, and the effect on quads and that sort of thing. But the reality is now, when you've got something that's much more targeted, if you're able to break the pain, which often results in more wastage, it's anecdotal, but with a lot of patients, you do normally see that their muscle strength improves over time. It is an area that we'd like to do more research into, but if you're enabling someone to better participate in activities of daily living, in exercise, these sorts of things, it's reasonable to expect that they would sort of get associated changes with their musculature.
Yeah, it was interesting you mentioned skiing, because actually we had a comment come in before we even started from Carol, who says that she has an unloaded brace of her own, and she thinks they're the bee's knees because it means she can carry on skiing. So so that's good. I don't know if it's an Össur brace. I presume there are other versions around.
There are different versions that exist. So they can work in very different ways. So certainly historically they tended to be more based on other braces rather than something that's designed from the ground up. And that's one of the key things, really. I talked a little bit about the fact that you have to consider the patient holistically. And if we've got a very rigid, very hard brace that traditionally you would associate with skiing, because the high level of ligament control required, that's potentially not suited for day-to-day life for that patient group. They want something that will fit underneath clothing, that they can adjust and will be absolutely comfortable for normal day-to-day living, rather than extreme high activities and long durations. Am I
right in thinking that with an unloader brace, it's targeted at unicompartmental OA?
Yes. So it's specific for, we can go on to the indications, but it's specific for any unicompartmental condition that would benefit from unloading. So that includes meniscal indications. They're also used in a variety, different varieties of them, from biomechanically very similar, can be used post microfracture treatment, for example, more other cartilage-based issues like Oates procedures, MACI and ACI procedures. And it's basically where you need to consider the load going through that compartment. The main thing really is unicompartmental osteoarthritis, and certainly originally we were thinking more about sort of lower levels, lower Kellgren-Lawrence levels, but they actually found that for all levels of osteoarthritis, they can be useful in affecting change.
And I think statistically, the medial compartment of the knee is most commonly affected. I don't even know if there are ever any problems with the lateral compartment. Can you work both sides?
Yeah, we have lateral versions. They account for sort of 20-30% of the ones we sell. So effectively, most of them are medial conditions. But you can get lateral versions, and that's not uncommon if someone has a valgus knee position or that sort of thing. So it's a different version, but we have them.
A couple of comments for you before we move on. Karen says she's just getting over an ACL reconstruction. I think that's going well, Karen. And she uses a Donjoy Playmaker brace, which completely tightened her MCL.
Okay.
It's a comment, and any observations from your part?
Yeah, so with those sorts of things, again, it's applying a medial lateral force to the knee. It works in a very different way. So with those, it's what's called a push-based mechanism. So you're using the hinge to physically push on the knee itself. With an unloader, you're actually using what's called a pull mechanism. There's a very simple study by Rosinski. I can't remember what year it was, but they described the two methods. And basically this relies on a pull mechanism. So if I can show you this here, rather than the hinge biomechanically sort of pushing and applying a rigid force to the knee, what we're actually doing is applying a counter force here and here with a large surface area, and then utilizing the straps on the lateral side. So you'll see this later once we actually go and fit one, but effectively you've got a very large surface area providing that force, but it's also dynamic as well. So one of the benefits is, as you bend your knee, as we're sat here now, you wouldn't necessarily want that unremitting force on your knee. But it just means that as you go into full extension and the articular surfaces that are affected by the osteoarthritis come in contact, you've got that force applied on your knee to reduce the load in that area.
It's not clear from what Karen says whether completely tightening the MCL is what she wanted or whether that was beneficial. So it'd be interesting to hear, Karen, if you want to come back to us on how well you're doing with that brace.
Yeah, so it's interesting. Some clinicians do use them effectively to stop that that valgus force opening that medial compartment. It's not one of our indications, but effectively using it the opposite way round to load the medial compartment to prevent the gapping associated with that ligament injury.
Robin says that his brace is a CTI OTS from Össur. That makes sense to you, does it?
Yes.
He got it after lots of research and ultimately decided after being impressed. He won't remember this because it was years ago by the time and help that Giles offered me on the phone. So you're responsible for Robin's brace, still going strong after years of wakeboarding. I'm not quite sure. That's probably Robin, who's the cyclist I spoke to you about earlier on, who like you is a mountain biker.
I understand, So that's again a very different brace. That was when I was talking about a ligament brace. We're wanting to promote structural integrity of the knee and preventing, effectively tibial translation, which is a relatively sort of small movement from a biomechanical point of view. So those need to be designed to be very rigid and very controlling. Whereas with something like this, we want something that's focused on providing that medial lateral force, being very, very lightweight. And it's not necessarily about rigid control of the knee. So the CTI is a great example of ligament brace, but those are more traditionally where OA braces came from, and in that lies the difference with something like this.
Okay. So you talked about indications earlier on, and I imagine that some of them might be fairly self-evident, but what are the indications that an unloader brace could be useful?
It's effectively anything where unicompartmental unloading is beneficial. So the primary one is mild to moderate OA. We then have degenerative meniscal indications, which from a manual therapy point of view can be quite tricky to manage. We then have the other ones that I've gone through. So things like microfracture, post MACI, ACI, and various cartilage based issues.
Any contraindications amongst that population?
Not necessarily. I mean, the things that we need to think about, standard orthotic considerations, are things like patients with neurological deficits, so sensory, neuropathic, sorry. So if they have a reduction in sensation, or if, for example, they have significant fluctuating edema, it's not necessarily a contraindication, but it's important that those are addressed and that you have sort of a heightened level of support for that patient. Just because they need to be aware that perhaps they need to wear it in sooner, they may need to adjust it as the day goes on, they may need to monitor the skin. So it's important to take those on a case-by-case basis.
So are these worn against the skin or over clothing?
So you can do both. Biomechanically, it would work exactly the same over clothing. The difficulty is with having it over clothing, you can see as I'm sat here, there are creases in my trousers, those sorts of things. Also the potential for slippage. So we design lots of things into the brace to make sure it stays put. We don't want it sliding down. So we use silicone liners the same as the silicone used in the prosthetic sockets I was talking about earlier. But if you put them over clothing, you have the potential for them to slide down a little bit more. So people do wear them over leggings and that sort of thing. But
you'd struggle to fit them under those jeans, wouldn't you?
For me, yes, potentially. But there are other clothing choices that you would wear, for example. So it does depend on the individual clothing. But we try to make them as lightweight and low profile as possible.
Okay. Karen's come back and said, yes, her brace helped with the MCL, but now I will need a brace, she says, for skiing post ACL surgery 9 months ago. So very interested in what we're going to be talking about today. Yeah. Functionally, I presume someone would wear this obviously for normal day-to-day activities, walking around. If they're cycling or in the gym or anything else like that, I presume this can still be worn over there and would perhaps be beneficial while they're
absolutely. They're and it's really individual in terms of saying when people should wear it. We have patients that get up in the morning, they immediately put their brace on, and then when they go to bed, they take it off. More commonly, if people wear it when they need it or when they're doing activities that would normally aggravate their knees. So, perhaps when you're in and around the house and you're used to your surroundings and that sort of thing, you wouldn't necessarily need it all the time. But we have the real gamut of patients, and OA specific, it's so individual in terms of when people have problems. I always say it should fit in with your lifestyle, and you should use it when you feel you need it. That said, the more you wear it, the more potential benefit you'll get. Yeah,
well, actually, a very timely question here, because Rupert's just said he had a patient who used an unloaded brace on his knee for some time, but it caused complications regarding venous return, and he's due to see a vascular surgeon soon. Do you have any comments about how much one should wear the brace? And obviously, you've just touched on that, but in this particular instance, if there is a problem with vascular return,
I mean, it's important to consider, just because with any brace of any type, there's going to be, in effect, a circular effect. Tightening of the straps means that it keeps it in place. So if there are significant vascular concerns, it's important that those are addressed beforehand as much as possible, whether that may be, I had a question this morning, believe it or not, that was just with regards to someone with poor venous return, and it might be appropriate to consider compression hosiery or that sort of thing, and try and address that before we then consider that. But for 90% of the population, that's not a problem at all.
In practical terms, what do you expect to achieve with one of these? I talked about it deferring surgery beforehand. Obviously, you've talked about pain relief, but how long would you expect that to last? Well, how long might you put off surgery for? Do people go without surgery altogether because they've got one of these?
Yeah, so it does depend on the individual. There was a study done, I'm just clicking through to that one, but looking at existing patients that were on the waiting list for surgery, and they actually found that this was done in Bridgend by Paul Lee, now Professor Paul Lee, and he was looking at 63 patients, and they effectively did EQ5D data, so it allows them to do a quality analysis, and they found that it was cost effective in these patients after a period of 4 months, and they were actually able to delay surgery, and felt it was both an effective and cost-effective way of delaying surgery in these patients. The mean wearing time for that was 26 months, so they do wear them for significant periods of time.
In just a second, we're going to get on to actually fitting the brace, but dare I ask, what is the cost of one of these things, and what's the route to getting one for a clinician who's got a patient they think might benefit?
Yeah, so there's various different routes. Our biggest customer is the NHS, so these are available through the NHS, and that's the bulk of our work, I would say. The other thing that's interesting with it is certainly private healthcare and these sorts of things. As an orthotist, often, or other allied health professions, private health insurance companies won't necessarily cover anything other than the clinical time. But this is actually the only OA brace that's fully funded by AXA. They will completely cover the use and prescription of the brace.
Fantastic.
So it's unusual in that way.
So if let's say I've got a patient who I think would benefit from this, my best option would be to write to his GP and say this person has got what seems like unicompartmental OA. Maybe I've got imagery to prove that. I think you would benefit from this brace. Are there nice guidelines which relate to this that we can refer to?
So yeah, there is nice guidelines in regard to bracing in general. I'll skip back through some of the slides, but effectively with those, NICE support the use of bracing in OA where there is associated joint instability, where there's abnormal biomechanical loading, and that really is the important part. Just because historically the mainstay of treatment for patients with OA is weight loss potentially if appropriate, patient advice and painkillers. And the difficulty with that is you're very much treating the symptom. You're not necessarily treating the cause of the biomechanical problem. So through using something like this, if we consider that in loading terms, there was a study that found that we're able to get about 15% load reduction in that compartment. It doesn't sound like a lot, but if you equate that to 15% load reduction from a body mass point of view, that's significant, and that's a big commitment from the patient.
So would the GP be able to recommend or refer a patient with one of these, or do they have to go to a consultant to get that?
It varies. Certainly historically, the route through to getting braces like this was always sort of through the orthopaedic surgeon. They would then be sent through to either an MSK service or potentially orthotics. It's much more broad now. So there are, for example, first contact practitioners associated with GP surgeries, for example, and they can actually refer on to these types of services. And it's quite varied in terms of who fits and who uses these braces. So orthotists, physiotherapists. There's some plaster techs in some hospitals that actually are fitting them, and OTs, for example. So it really does vary in terms of where you can access these.
What's the waiting time at the moment for a patient to get from making it known to a GP that they think that one of these might be good to getting to the point where they're prescribed one?
Depends where you are. So it can change. I mean, obviously if you're doing it privately, it's significantly quicker, but a lot of trusts are using unloader braces, and the thing is, with studies like the one done by Professor Lee, it's basically showing it as a cost-effective way of doing it, and a lot of surgeons are perhaps limited in what surgery they can do at the moment, so they need something that will actually can manage these patients while they're waiting. And for a lot of people, it does turn into their definitive treatment for the time being.
Let's, rather than spend too much time sitting here, let's go across and fit one of these to Jack, our regular model on the show. So you can tell us how difficult or easy it is to do that. And we can see the thing in action.
Sounds good.
Right, so the sad thing about this is that Jack doesn't have a knee problem, which is good for you, Jack. But we're going to fit a knee brace to him anyway.
Okay. So in this case, we were already sized up Jack, so I already knew his measurements before we started.
What would you measure?
So what we would do is we'd take a circumferential measure. So can I get you to stand up if that's okay? So just sort of looking down here, all we're doing is taking a depth there at 15 centimetres. We're taking a circumferential... 15
centimetres from the bottom of the patella?
Mid-patella, yeah.
Mid-patella.
And this then gives us a size. So in this case, is about 36, which would put him in the region of a medium brace. From a sizing point of view, we've just changed this recently. So the extra small to medium is one size, and then there's a large to double XL. The other thing that's very important to know is which is the affected compartment. So in this case, Jack doesn't have medial compartment OA, but it's a right leg on the medial side. So we would have we have that brace, but effectively 80%, 70 to 80% tend to be medial. If it's lateral, you just order a lateral version. And the brace is effectively identical. It's just that the shaping is very different on the lateral sides. So we've sized him up accordingly. We would then order the brace. We've recently changed all our packaging and that sort of thing, so it's all much more green and recyclable. And effectively, this is the way the brace arrives. And one of the things that we use, I talked about them being designed holistically, but we're trying to avoid D-rings and things like that without having to thread straps through and that sort of thing. So in terms of application, It just has a simple color-coded system. So we have blue here and blue here. They click that in and then fold that over. Exactly the same at the top. So what I often would say to patients is kind of ignore the fitting side of things that I'm doing initially, because effectively it's 2 clips for them, and then they're then good to go. So have a seat again, if that's okay. So I'm just going to straighten your leg, and if you just slide forward a little bit, because what we need to do is actually get this in position here. So important thing is making sure that we've got this position correctly. Everyone always wants to fit it, all braces a little bit low. So this logo here, we're lining up with the top of the patella. The hinge here, we want at the midline here like that. And what we're actually doing is we're bringing this strap around, fastening blue on blue. And again, this stage is really what the clinician is doing. You don't really need to, the patient won't do any of these stages. And then tightening the strap, and you can trim all these if you need to. So that goes up and over the calf. And then we're then fastening the top section. So again, yellow on yellow. Now this is quite loose at the moment, bear with me. And we're just going to fasten this thigh strap here. Now we have this ability to tighten this at the front.
You've got those wonderful little boa devices, which I've got on my cycling shoes. They're fantastic.
Exactly. So those are really good for micro adjustments. And what they're there for is for the patient to adjust themselves. So say, for example, your knee was particularly comfortable doing a specific activity, you can actually increase or decrease these dependent on your pain relief needs. So can I get to stand up? And what I'm actually going to do is just set up these diagonal straps. So these are called dynamic force straps. And the dynamic bit comes in as a result of the fact that when you actually flex your knee, you don't actually necessarily need that same level of unloading. Just going to go a touch tighter on there. You don't necessarily need that same level of unloading. So you see when Jack actually bends his knee, these will actually go loose to some extent. And that's in line with where the area affected by the osteoarthritis is, because it's normally in the last sort of 10 to 15 degrees to full extension. So all I'm doing here, obviously normally I would trim these after I've initially fitted this, but we've got it in position. Have a seat again. And then I will just tighten these up. Now the ideal position is to have it in the central section. It used to be 5, and I always try and stop myself doing that. But we're tightening these up. And then if you just straighten your leg for me, you should be able to feel a little bit of force there, and we can just check the strap tension. So describing strap tension is quite tricky. The other thing that we would consider is the patient's skin condition. So in this case, really good skin condition, and we wouldn't have any concerns with having these nice and tight.
So when you said the central section should be 5, what are you referring to?
Just this here. So it's now this sort of circular window. That's the midpoint. So I'm just setting this up. So just bend your knee a little bit, because at the moment I'm using these smart dosing dials just to set it up. But when the patient leaves, we would always adjust it so that their correct level of tightness is at the midline. So they can go tighter if they need to, they can slacken it off if they need to. And really reducing the tension is more to do with volume changes. If there's any swelling or whatever, they've got the capacity to adjust that. So straighten your leg again for me.
Carol's actually asked whether you do replacement straps, because she said they tend to stretch.
They can do a little bit over time. The thing to bear in mind is when they're in a box, there's no stress on them. So we would always recommend a review within sort of 4 to 6 weeks, just to readjust it. It also means you can solve some of the little problems that come along. So straps are completely replaceable with the manufacturers, so we can get hold of basically all the parts for it. The only things we can't sort of replace on them is if something integral to the hinge or the frame is broken. But all the straps can be replaced, all the pads can be replaced, the buckles, most parts can actually be replaced if you need to.
So once you've fitted this, there's not much for the patient to think about?
No.
And how much training does it require to fit them? Would you expect, let's say if one of our audience, osteopathic chiropractor, said, I want to be able to do this. Is this a sort of an hour's training in the morning, or is it a lengthy course?
No, so we would often sort of come and support you for the first couple if that's something you wanted.
Yeah.
We do have lots of resources, whether it's on YouTube. We even have e-learning courses and that sort of thing. So,
the curious thing you were saying to me before is actually you've got the same cameras we've got, and you're using very similar systems to us for Össur's own education academy.
Yeah,
I haven't been there, but I'd recommend people take a look at it because you've got lots of stuff there which would be useful as a CPD product for people, wouldn't they?
And that was, from our point of view, that was a reaction to the fact that fitting them, if I just show it on a PowerPoint or whatever, it doesn't necessarily get across the technical aspects of it. And obviously here you have the ability to show different camera views and that sort of thing.
Yeah, of course.
And it was something that we developed as well. So effectively, if I can get you to stand up for me, it's important to check the hinge position, but just check the tension here either side. I'm going to go a touch tighter on this one.
So with the hinge, we're looking at the logo there's probably on the joint line now, isn't it?
So basically, you do find that it will just kind of settle into position. So we need to make sure that we've got it correct there. The front of the hinge should be roughly at the midline, but you'll feel, as you can see here, as you go straight, Jack, you can probably feel a bit of pressure on this side, and effectively the 3-point pressure system that it's applying. A lot of patients with medial compartment issues, effectively the load line is moving medially in sort of a varus style position. So what this is in effect doing is applying a valgus force to a varus leg to reduce the load in that medial compartment. So these two straps are pushing that way. These two large surface area shells are effectively pushing laterally. So it means you've got this dynamic force. So if you sit down again, Jack, you can see that as we flex, it reduces some of the tension on there. You can probably feel that quite
comfortable?
a bit.
Yeah, very comfortable.
Yeah. And we also use things like, for example, that I mentioned before, but silicone on the bottom section to make sure it anchors and stays in position. So,
what about just behind your knee? Because it looks like there's a lot of straps there sort of being gripped behind the knee there.
Stand up and then spin round. So I just need to make a little tiny adjustment there. But we've got a big popliteal pad here, just so that it means that you've got plenty of padding in there, and you can move that around if you need to. But as I mentioned, it's dynamic, so it's not unremitting in terms of that force.
Yeah, sure.
But generally, people find them pretty comfortable.
Should we get Jack to walk up and down? And
sounds good.
I don't think we're going to see any difference in Jack because he'd never problem to start with.
He's symptomatically.
He's fine over there. Just have a little walk towards the camera over that way. And when you're walking, Jack, does that feel perfectly normal, perfectly fine?
Yeah, it does feel normal. It takes a little while. You can feel that there's something there, but after a while I know I won't feel like it's there, if that makes sense.
So if you could keep walking, if that's okay. So effectively, what if you notice, certainly when he's walking backwards, you can see that there's a change in the tension of those. But that's just to do with the fact that the area affected by the osteoarthritis really is in that last sort of 10 to 15 degrees. So.
It is actually, I mean, there is substance to it, but it's a lot less bulky than some knee braces and less bulky than I was expecting.
Yeah, and this weighs just over 300 grams. It's not particularly heavy. It will fit underneath clothing. Yep. And the thing is, people think brace, they think perhaps a bit Forrest Gumpish or that type of thing. And the reality is very different now. We're using a lot of technology, things like plastics and carbon fibre and silicone and these types of things.
And how does it feel behind the knee where you've got the straps?
It feels like I'm very supported there, and it does actually feel very comfortable as well when it's on.
Okay. Yeah.
And the other thing to show you perhaps is adjusting these. I mean, you're not symptomatic, so it's tricky, but if I go just a few clicks up, which again would normally best practice do this with the leg inflection, but it actually you'll feel it's probably quite a bit stronger now.
Yeah.
But it means that patients can actually control their own pain levels. So if they are doing something that's particularly uncomfortable for them normally, whether that's descending a slope, upstairs, these types of things, through their clothing, they can just tighten those up and increase the amount of force the brace is applying.
So we've now buggered up his lateral compartment, have we? Tightening up too much.
I always say that the load has to go through the knee somewhere, and what it's about is reducing the load in the area that's worst affected. A surgeon, if they're going to be replacing the knee, most of them will replace the whole joint. So, it's important to keep that person active and allow them to do their activities as normal daily living.
Brilliant. Jack, thank you. Let's get back over to our seats for a second. I've got a load of more questions that have come in. So, the first one is, I'm taking these in order. I'm on my chart here rather than relevance to what we were just discussing. Robin says, what brace would you suggest for a medial meniscus tear, no OA?
So I mentioned before, probably the slide on the indications if it's in here somewhere. There we go. It can be used for degenerative meniscal injury. So there is another version that's designed for cartilage-based issues. So something called the rebound cartilage, and the difference with that one is it actually applies the unloading into higher degrees of flexion.
Right.
The indications are the same, but it has a slightly different feature to it.
Right. This says unloader 1. I mean, how many unloaders are there?
So we have the Unloader 1X, which is this one that we've shown you today. We have the Unloader 1 Smart Dosing, so the older version of this. We also have a couple of braces that use very similar biomechanics. So things like the rebound cartilage is designed for cartilage or more trauma acquired injuries. We then have other ones that are for sort of lower levels of unloading and different patient groups. So things like some of our other OA braces can be used for things like there's one called the OAEs, which is sleeve-based, lower levels of unloading, but perhaps more suited for patients that are just beginning on that journey into osteoarthritis.
Okay. Susie asks about inflammatory arthritis, because everything we've mentioned so far has been OA, of course, and unicompartmental at that. Mm-hmm. She says that from your comments about edema, it sounds as though inflammatory arthritis might be more complicated.
It can be. I mean, with inflammatory conditions, it's affecting the whole joint. But what's important to consider is if you think that there is a biomechanical component to it, and if the pain is very much located in one of the compartments, the good thing with this type of conservative intervention is you're actually not going to lose anything by trying. With these patients, it may be something you can consider fitting. But it's important, with an inflammatory condition, it is affecting the whole compartment. But it could be that the pain's located on one side. Okay. A good example with this would be, not necessarily from the inflammatory point of view, but these can be used as a prescription tool for things like high tibia osteotomy. So a lot of surgeons will actually fit those to see if biomechanically unloading that compartment is effective before they then go into the cost and the complexities of a high tibial osteotomy, for example. Yeah,
did you tell me what the cost of these is?
So the cost to clinicians is about in the region of £430 plus VAT. Okay. Obviously, there's a different price for members of the public that are fitting those. So yeah.
And getting back to how a patient might get one of these, I mean, if a private patient with an osteopath or a chiropractor came in and it was decided this would be good, they can come straight to you, get them through you. Yep. They can add whatever markup they want to that price for the patients, or do you say, no, it's got to be this so that we don't end up with differentiation across the market?
With the sort of, I briefly showed a map earlier just showing some of the clinics that we have links with in terms of if someone phones up and says, I would like an unloader, then that would be the group that we would send them to. So there are prices associated with that. So we kind of, I think it's £650 fitted. So we kind of recommend it, but you're quite right. It's something that can be set by the individual clinician.
Kim says she's got a client who plays hockey. Can you wear these while you're playing sport, in particular hockey?
Yeah, their use in activity, is there are lots of people that wear them for all sorts of different activities. One thing that's important to consider, we get asked about swimming, for example, all the time, but really it's not of use in that, even though the brace is completely waterproof, you can even put it in the washing machine. But it's about considering, it's less of an issue with these, but the CTI that was mentioned earlier can fully cope with things like football and that sort of thing. But you may, if you clash knees with someone, the other person will come off considerably worse. So we don't recommend that the unloader specifically is using anything significantly contact. But if you were to put, some sports, they put sleeves over the top of them to cover them. And then, from an activity level point of view, it's not a problem.
Okay. 2 questions, one about osteotomy, one about knee replacement. If the patient's still experiencing pain after that surgery, will these potentially help?
You mean after an arthroplasty?
Yes.
I would say probably the main situation where they're used, and this is getting quite niche and quite unusual, would be where there's the consultant feels that there is a loading related issue to that pain, a loading related component to it. So some people do, but I would say that's quite unusual.
Right. Okay. Excuse me. There's a couple of questions here which we have discussed a little bit in the past, but maybe we need to elaborate a little. Gabrielle says, can they be used for other reasons than simply delaying surgery?
Yeah, I mean, there's lots of different situations where you would use these. People are using them to maintain their activity levels. If you are wanting to be active, but actually the pain of activity is causing you problems and it's not allowing you to walk the dog, cycle, or whatever, these types of things. People are using them for that. And increasingly, we're seeing quite a younger population that are wanting to keep up with these activities. And surgery is, very effective and a great way to go. But it's about considering all of the conservative measures before you then go to the much more definitive surgery side of things. So yeah.
Yeah. And still some concern about irritation of one sort or another. Robin says, do you ever have any issues with the straps irritating the common perineal nerve? And Bridget says, would that be a fitment issue? Are there any issues with skin abrasion or rubbing?
So there are a few things in that. So it's really important that we spend a bit of time with the patient to describe building up the time you wear it slowly. So it's kind of like a new pair of walking boots or whatever.
Yeah.
You don't immediately put them on, or hopefully don't immediately put them on and then go for a big long hike. We provide advice about building up the time you wear it and also building up the activity level for how long you wear it. So that is a real part of getting both you used to it biomechanically, but also your skin getting used to the sensation and the effect of the straps on there. We also have other things as well, so alternative liners. We have different paddings, different materials, these sorts of things.
Okay.
We even have things like there's a dexterity kit if someone has poor hand function. They may struggle with the boas, for example. Right. So there is a version that makes it much easier.
So in terms of me as a clinician prescribing one of these to one of my patients, if some of these things happen, do I just call you up and you say, I might have just the thing to fix that, and you come and help me out? Or
it's a combination. So we do have salespeople across the country who are very experienced with these things. So
but also will help out basically if those things happen.
It's in our interest for you to get the best, you and the patient to get the best outcome out of there. So by all means contact us. I think it was Robin earlier mentioned that I'd spoken to him in the past. We're happy to support in that way. And obviously we're quite unusual from a bracing point of view in that we have clinician support for these types of things. So certainly my role historically has been to support clinicians such as yourself.
Speaking of Robin, he says, this feels like a silly question, but is the measurement the same for all knee braces?
No. So it depends on what it is. We would love to standardize it, but the reality is that a brace like an unloader, there's quite a large fitting window. So the sizing isn't as pivotal as it would be in the CTI, just because that one relies on a bony measure across the knee. So it would be great if we had one measurement that meant you could have it for all of them. Unfortunately, it's a case of remembering.
Kim's come back in about her hockey player and says that the hockey player's got a medial compartment problem and they're looking at high tibial osteotomy. Personally, it sounds from what you said as they're an ideal case, because this might show that the osteotomy might work, but it also might help them during their sport in the meantime.
Exactly, and it's a little bit about prehab. First of all, we're proving the concept. So with a high tibial osteotomy, they will add or remove a wedge from the tibia in order to realign the leg effectively and change the load line. And the brace is doing a similar thing, effectively applying a valgus force to a varus leg, or opposite if you have a valgus leg. But it's about seeing what effect changing the load line, where the load is being borne through the leg. So hopefully you can see and predict how well that's going to work before you go for that definitive surgery.
Just a few seconds, and we've got a couple of other questions. Any good for a 90-year-old plus patient who's got medial OA, but won't get surgery because of their age? Sounds great to me.
Yeah, I mean, it's important to consider various different things. So skin condition, these types of things, whether they have the dexterity or perhaps the cognition. So some of these, I mentioned very briefly the OAEs, but a sleeve-based design that's very, very, very simple to put on. So that might be something to consider. But we have patients who are very elderly that are wearing these and get on very well with them.
Giles, we've got no more time.
That's right.
I've got 4 or 5 questions that have just come in. I don't have time to ask them on air, but I will get answers from Giles before he leaves today, and I'll send them out with my follow-up email, which I will also include a handout of Giles's slides, contact details for Össur and so on, in case you're interested in using these things. Yeah, but there you are. As far as I can see, this is a great alternative string to your clinical bow, or additional string to your clinical bow.